So everyone blames their medical school for teaching too much, too fast, and expecting everyone to have mastered it in 3 hours. That misses the point. The real point is medicine isn't hard, it's long. So you do have to know a lot. The challenge now is, how do you remember a lot when there's a lot to remember? And the answer is because you're going to use it in patient care. When you start organizing these large, vast bodies of knowledge, they're actually quite memorable if you know why you need to know them. So it's not a question of volume. There's no way around that. It's a question of organization. How do I need this fact, and where do I put it so it pops up right when I need it? Just enough, just in time. So if you want to criticize your medical school, don't do it because they're dumping a lot on you. Do it because they're not doing it in a way that makes it really sticky. Come to a lecture, a good lecture on heart, and you just wish you were going to heart clinic next because you're kind of excited to see it. So don't per se blame your med school. Have a better way to organize it. And frankly, that's why we're starting this whole organization and community. Part of what we're going to do as a community is every week, I'm going to share with you what I'm doing and what I'm discovering that's new. And I hope you'll find it as compelling as I do. So I'm the Dr. Philip Tisdall, and I've been reading your comments. I read them religiously for a simple reason. You teach me to teach. So today I want to respond to your comments and see if I can't help you understand better the comment that you made. So a common complaint is there's way more to learn today than there was back in my day, which I mean, it hurts a little bit. It was the 70s, not the 60s, but I get the point. Well, the truth of the matter is there is more data, but with it, there are better explanations. So that in my day, you'd come and say, so why do they look like that? And your very experienced clinician would say, you see that. Because we didn't have any idea. We were fantastic on phenotypes, but that was it. Now you can come in and say, what am I feeling? And you get a CT scan. And you go, oh, look, it's a mass. And you put a needle in and you say, oh, look, it's a lymphoma. Then you say, well, what kind of lymphoma is? You go, well, let's talk about what the cell looks like, and let's talk about how the cell marks. So yes, there's more data points, but there's profoundly more understanding. So then it's just a question of, you get to finish the story. So they don't just ride off into the sunset and you never know what happens. Now you get to follow it. And that's a comment we're going to have to do a video on, which I call completeness. In my day, as in yours, you start with a psychosocial cultural human that's going to come in with a problem that you're going to make the chief complaint go to an organ. But anatomically, organs sit in regions, right? So organ sits in a region, heart sits in the thorax. So regional, organ, surface, internal structure. Okay, oh, wow, we have so much more to learn. Right, but you actually get to do a short axis view and a long axis view of the heart. You know what we got? Nothing. We had a stethoscope with a couple of little wrinkles. So yes, there's more to learn, but you want to know it. You want to know there's a hypertrophy or papillary muscle necrosis. We just had a couple of data points and guessed. Then you go to show me ultrastructure. Well, okay, there's tissue organization, there's the cell, and there's the ultrastructure in the organ. Well, we were way better at histology, and you know why? Because there was so little to learn, we actually learned all of that, but it gave us this really powerful ability to understand cells. The biggest gap I have when I teach you guys now is that you don't have cellular architectural vision in your head because you've been doing so many other things. So just because you're learning more, don't think that what you're learning is better. Sometimes it's not. And then proteins. I mean, we must have had 3 proteins back in my day. You guys must be up to about 4,000 or 8,000 of the 30 some odd in the body, but they really are powerful. So for example, in my generation, alpha-1 antitrypsin was a pink blob in a hepatocyte. Now you guys know it's a misfolded protein that can't clear the SER. Is that more to know? Yes, but it finishes your story. It's not harder to know that. And then when we come to the DNA, well, we sort of had DNA and you have a lot more DNA. And let's face it, even now, none of us really understands it. So they don't really test it heavily. We sort of go, down there in DNA land. So yes, of course, there's more to know, but it explains more. So it organizes better. I don't think the burden of learning is harder now. Frankly, I kind of think it's easier. A common theme that I have is you have to change the way you're learning. And lots of comments that come back, hey, don't blame me. I'm trying as hard as I can. Well, remember the name of our system is Medical School Companion. We're not going to change the world. Medical schools are very powerful, deep legacy institutions. But that doesn't mean you can't take all the facts you've got and say, is there a way of learning them that seems more natural and permanent? And what I'm telling you is, yes, what's different between you and back in my day? And the big difference is this. We were going to really profound apprenticeships. There were very few of us. We were all made men. There was no competition for residencies. So they didn't really care what we learned as long as we learned something, because they were going to throw us into the deep end of clinical medicine where we were first called for everything. Anything we didn't know, we had ample residents to watch us do everything we did. And so we learned medicine as apprentices. That's what's changed. So now you have to go into what is not an apprenticeship. For the most part, it's going to be an observership. So that means you've got to go in with a deeper clinical understanding. And because medicine has such good understanding now with its testing of morphology and proteins, you have to have a complete understanding going in. So what's really changed is not that there's a lot of information. I never understood why I had to learn it all in 9 months. Why couldn't we just take 16 and I would have enjoyed it? Totally agree. But here we are. So if that's the game and I don't get to change the system, what I'm telling you is, let's take a patient-centered approach, which is really natural, really sticky. You're going to use it immediately to clerkship. And oh, by the way, that's your exam. So you know what you really should pay attention to is this. If you're complaining you don't get a chance to learn material, totally agree, neither did I. Remember, there's only two things you really care about. Am I going to pass my exam? For sure, that's fair. And the second is, am I going to know what's going on in the wards? So what I'm telling you is, it's a clinical exam. The only decision you have to make is whether you believe me or not. You know, the guy who's taught over 4,000 students has had all their feedback directly writing after step one, who knew them as student learners, that guy, or your friend who got a really high score eating only bananas before he wrote a step one. So all you have to decide is, am I entitled to opinion on the best way to prepare for your exam? And oh, by the way, having practiced for 40 years, am I the right guy to say what you're going to need to do when you confront patients? So if you don't believe me, that's great. Good luck, and I wish you well. But trust me, I am right. Some of you have legitimately pointed out that I haven't eliminated memorizing. Well, I've thought long and hard about that. I mean, it really bothers me a lot. Here's what I've got to say, a qualification and then maybe an insight. The qualification is this. When I use the word memorizing, I mean rote memorizing. These are the presidents of the United States in a list. No context, just the list. And you're going to be examined on the list. That's rote memorizing. You still have to learn things, and we learn things by putting them into our brains through repetition. So in that sense, it is memorizing. There's no way to solve that for me. The only way you could avoid that would be if you had an apprenticeship where you started seeing patients first day, and then you'd read the odd interesting thing at night. If you could do that, we really wouldn't have to memorize, but that's not our system. So the question's going to be, how can I learn in a way that is in context and usable? So I accept that you do have to practice. There's no way around that. I practice before I lecture you guys. What I'm telling you is this. Human memory has a number of technical facts about it. Here's a couple you've got to understand. Cognitive load theory says, if I'm teaching you something new, you can only have 4, maybe 6 or 7 elements in your short-term memory when I'm talking about it. When I say congestive heart failure, if you've got the same picture I do, I've only used 1 element. So I can teach you something new about that quite easily because you've got lots of bandwidth for learning. But if all you have is a bunch of words, I'm going to fill up your memory and you haven't got room for something new. So first thing about the way we're doing it is it gives you powerful blocks of knowledge that you can really learn from. The second is humans are visual. 40% of our brain is visual. We see things. And, this is called the memory mansion. Sketchy uses it. When I went to Sketchy, I went, this is a great idea. Why do they use a dragon? Why don't they just draw the heart? So what we're doing is no different than what Sketchy does. It's using this idea that people love pictures. The only difference is I'm using the pictures of medicine. So it's a twofer, right? It's a great way to tap into your visual memory system, but it also teaches you exactly what you're going to see. So why wouldn't you do it that way? And then the third thing we're doing is we're telling stories. Humans love stories. So when I say to you, we're going to start with chest pain. Can you see the thorax? Here's the heart. Did you see the LAD? When we're doing anatomy, structure, function, you can see I'm telling you a story. Let's pinch off that LAD. Got a little picture of cholesterol going in here. Come on down to the occlusion. We're going through cell death. Let's talk about ischemia and that. These are all very natural for us. And so when you're learning, you don't have any gaps. And you have something must follow here. You know to look for it, as opposed to just a bunch of random scattered shotgun facts. So, yep, you do have to repeat it. You do have to work at having this knowledge. If you want to blame that on memory, I can't stop you. Yep, you do have to practice that. So I've had a number of comments that have said, hey, great, glad you want to teach. Too bad you're using it to sell your product. Well, I am using it to sell my product. It's the book. I got it right here. Buy it. I make no apology for wanting to sell that to you. It has costs. Life has costs. Production has costs. Hey, does your medical school charge a tuition? That's right. All those .orgs all have money. One of the challenges you're going to face in medicine, you will never separate patient care from business. It's one of the paradoxes. It's a tension that lies at the heart of medicine, always has and always will. So no money, no mission. If you think I'm doing this to get rich, then all I can tell you is I make a third of what I made in practice. No one in their right mind goes into teaching to make money, but they do have production values and they do have ambitions to go into other countries, and they do ultimately have ambitions to maybe bring this to people that can't pay at all in other countries. The second point I want to make is this. If someone won't pay for your product, is it really a good product? And this is the story of Weight Watchers. This is an astonishing story. Weight Watchers was a .org. They would help you lose weight for free. And people wouldn't come. And so what they started doing was charging. And people came. So frankly, I feel like charging you guys a lot because I know that human psyche says, if this is really expensive, it must be really valuable. So thanks for putting that thought in my head. Your friends will appreciate it. So the site's been looked at by a number of people who aren't on the MD track. Nurses is a common group. And I can tell you this, in my day, doctors were officers, nurses were enlisted. It was a bright line. I got to tell you, that line doesn't exist anymore. It doesn't exist. If you're a nurse, I don't have any idea what you do or your level of independence. You could be a very basic nurse that's doing very basic care, all the way up to some of the truly rock and roll nurses in the ICU. When we brought in a cardiac ICU in my hospital, the only people that were allowed to write prescriptions was the cardiologist who ran it and the nurses in it. And the internists who had built the hospital and built the unit were out. They were beside themselves angry. And they were unamused when I pointed out to them. The nurses actually knew more about what was going on than they did because they were generalists and the nurses were specialists. There are other situations where you find nurse specialists that are just more knowledgeable. Obstetrics comes to mind. Your busy OB nurses, they really know a lot. In the ER, you find the line really blurs, don't you? Those ER nurses are rock and roll, man. I mean, they really get in there and do patient care. And then there's actually legal shifts now. What is a nurse practitioner? I mean, don't tell me they don't practice independently. Oh, they're supervised by a doctor. Oh, sure. Like anyone who's ever been in an office knows that's not true. What is a PA? I actually have a PA, not an MD. Because I know that the doctor's doing all the clerical work and could care less. She's way too busy. My PA really wants to do patient care. They're a whole genre of people. And in my teaching, I've had PAs come to my courses because they want to get ready for the exam. And one of them told me he saw 30 patients a day, was making $250,000. I said, why the heck would you give that up to make less as a doctor? And he said, well, my kids are growing up. I really do love this. And my hospital has told me I can't run change and run systems until I have an MD. So I'm just doing that. And I went, well, that makes really good sense. You notice he didn't say, so I'd be better at patient care. He was already doing that. So Should you be doing this? The answer is go look in the mirror and ask yourself, what level of patient care do you want to have? Because that's really all we're talking about is, what do you need to know for proper patient care? And so this book doesn't define legal limits. It just says, this is everything you know at the level of general surgery, general internal medicine, and family practice. That's what the book says. And so you decide for yourself what level of care you're at. If you found this helpful, be sure to tune in next week, where I'm going to talk about understanding the idea of chronic progressive disease. It's an easy phrase to use. It's actually a really profound and nuanced idea. You can also watch my previous podcast with my really close professional friend, Nancy Selfridge, and that, I think, will be quite inspiring about all of us as students. Be sure to leave your comments. I'll see you next time.